presentation number 4 in genital urinary imaging series prepared by Prof. Sharaf. It will be for cystic and other diseases of the kidneys and ureters. Now, what is this? This is an image showing that there is delay excretion and diminished pyelographic density as well as reduced nephrographic density, and the kidney as a whole is smaller than the kidney on the other side. Now, the first impression could be due to something under perfusion of the kidney, and this means that the renal artery may be stenosed. So what to do? Previously we were doing the minute sequence urography, that is a film done every minute in the early 5 minutes. So we'll notice that there is difference in size, in nephrographic density. In pyelographic density, there is no pyelogram here. So this point to a diseased kidney. After a while, we give 2, 3, 4, 5 shots to get films, and then 15 minutes later we give a small dose of diuretic that clears the contrast in the normal kidney and augments the contrast on the diseased kidney. So this is the principle of what we call the rapid sequence urography. Now it's no longer used, and we resort to renal angiography, or better now to do CT angiography. And of course, renal artery stenosis is a cause for decreased function and for hypertension. Papillary necrosis can occur in sickle cell anemia. Notice the spider leg appearance of the calyces, spider leg appearance of the fornices. Minor fornices are like a spider down and there, attenuated, and this is called papillary necrosis due to sickle cell disease. And here is the papillary necrosis due to analgesic abuse, the golf ball appearance that is, there is some contrast seen in the concavity of the tip of the pyramid. Some contrast at the tip of the pyramid is called papillary necrosis due to analgesic abuse. And here the calyces might be flattened, might be showing blunted fornices. This is called the golf ball appearance. Now this kidney has increased echogenicity. There is increased echogenicity or increased echo-reflectivity. Of the renal parenchyma with loss of the renal parenchymal sinus. There is no distinction between cortex and the medulla, and this is called advanced renal medical disease. The word echogenicity could be replaced by another word called echo-reflectivity. What is this? This is a famous retrocaval ureter where the kidney and the ureter are too much dilated, and then U-shaped appearance of the tapering ureter is seen, denoting that the ureter is encircled, encircling the vein. This is an indentation of a vascular aneurysm, and this what a retroperitoneal mass can do. A large retroperitoneal mass can push both kidneys aside, can push the ureters aside, can do some rotation of the kidneys, and the spleen here it appears enlarged, soft tissue shadow of the spleen appears enlarged, and this is the typical appearance of a retroperitoneal mass. We were differentiating masses before by the effect on the kidneys. If the kidneys are affected by displacement, that means that the mass is retroperitoneal, and if not, the mass this does not mean that the mass is retroperitoneal. Of course, there is evidence of prostate, enlarged prostate. Here we have the psoas shadow, very eminent, very prominent here and there. This means that there is severe spasm, and the ureter are somewhat deviated medially, and the deviation of the ureter should follow the concavity of the pelvis. The ureters are not following. That means that there is something at the retroperitoneum here, either a retroperitoneal mass or retroperitoneal fibrosis can start like that. Psoas enlargement and psoas muscle tone can result in the same process. What are these? Number one is the simple cyst of the kidney. Number two is the hemorrhagic acquired cystic kidney disease, which is due to development of cysts in old age, chronic renal failure, or end-stage renal disease undergoing dialysis can produce such an appearance. Here, if there is a medullary cystic disorder in a baby, this is a baby with medullary cystic disorder, and this is the adult type of polycystic kidney disease. Adult polycystic kidney disease. So we have the adult, and we have the polycystic kidney disease of the infancy. The difference is that the cysts are along the proximal renal tubules and the proximal collecting system, while here the cysts are, myriads of cysts are seen involving the junctional area between excretory and collecting renal tubules. These are the examples of simple cyst. Simple cyst, a cyst with more enlarging in size rapidly or reaching more than 10 centimeters may need to be evacuated and ablated. This is a renal cyst, simple renal cyst. A cyst may be seen at the region of the pelvis, and in this case it will cause some obstruction of the renal collecting system, but usually it is intraparenchymal or on the surface. Simple cyst. Medullary sponge kidney is a cystic disease again. It is due to cystic dilatation of the renal tubules near to the tip of the pyramid. It may result in calcifications and stone formations, and it may result in this sun ray appearance due to contrast seen in dilated terminal collecting tubules, and thus appears as bunch of grapes like that and like this, related to the calyx but within the parenchyma. It's either we can see the striations of the dilated small terminal collecting tubules, or we can see the calcification and stone formation seen within these areas, within these cups of calyces, and this is called the medullary sponge kidney. Mind you that medullary sponge kidney can affect only one calyx, more than one calyx, half of the kidney, both kidneys, so there is variability, and we should be able to distinguish medullary sponge kidney from that diseases that can be caused, from that conditions that can be caused by prolonged compression on the kidneys. That means intravasation of contrast or reflux of contrast into the terminal renal tubules. This is called tubular tubular backflow. It's called tubular backflow. Polycystic disease of the kidney, it is an autosomal dominant disease. Third most relevant cause, prevalent cause of chronic renal failure, cystic dilatation of Woman's capsule, lobe of Henle, proximal convoluted tubules coexisting with normal tissue. This cystic dilatation of this group of excreted tubules, the Bowman's, the lobe of Henle, the proximal convoluted, is due to obstruction at the level between excretory tubules and collecting tubules. Male to female is 1:1, mean age is 43. Bilateral large kidneys with multiple lesions, multiple cystic lesions, may show calcific rings or rings. Distorted, attenuated collecting system. Nodular contrast on delayed images can appear as Swiss cheese. This is called the Swiss cheese nephrogram. Polycystic kidney disease shrinks after renal failure. Polycystic kidneys shrink after renal failure. Transplantation or chronic hemodialysis, all can result in shrinkage. May be associated with cysts in the liver in up to 50%, pancreas in up to 9%, and may be associated with aneurysm, saccular aneurysm of cerebral vessels, mitral valve prolapse, and of course there is chance for hypertension up to 70%. It should be differentiated from hydronephrosis. As in hydronephrosis, the collecting system is directed towards the pelvis. The complications are death from uremia, cerebral hemorrhage secondary to hypertension or rupture aneurysm, cardiac the cause may be cardiac, cause may be due to calculi infection or cyst rupture and the hemorrhage, calcifications. The differential diagnosis is multiple simple cysts, von Hippel-Lindau disease, which is cerebellar hemangioblastomas, retinal hemangiomas, and occasionally pheochromocytomas. This is a triad of the von Hippel-Lindau disease. Acquired uremic cystic disease, kidneys are small, no renal function, transplant all of this can be differential diagnosis. An acquired uremic cystic disease. The kidneys here are small and no renal function. All need transplant. This should be differentiated from infantile polycystic kidney disease. Here you find the calyces stretched and the pelvis, the double pelvis is displaced. That means that there are multiple cysts here, and the cysts are here enclosed within the calyces, which are splayed from each other, and this should be differentiated from hydronephrosis, and the ultrasound can help you in such thing. The complications are many: uremia, cerebral hemorrhage, calculi, infection, cyst rupture, hemorrhage, and the differential is multiple simple cysts, or some syndromes or like von Hippel-Lindau, and we should differentiate from acquired cystic disease with cysts, acquired uremic cystic diseases, and of course all needs transplant and should be differentiated from the infantile type of polycystic kidney. Autosomal, what is the infantile type? It is autosomal recessive polycystic disease of childhood. There is dilatation of the collecting tubules resulting in multiple 1 to 2 millimeter cysts. Results the dilatation in the collecting tubules, not in the excreted tubules. The liver and pancreatic fibrosis may be there. Neonatal in 60%, infantile in 20%, juvenile in 10%, and all are involved the collecting tubules are those involved tubules. We can find in the infancy the sunburst nephrogram, striated nephrogram with persistent radiating opaque streaks of the collecting ducts filled with contrast on delayed images, and the kidneys are too much enlarged, so bilateral markedly enlarged kidneys with streaky parenchyma due to contrast filling the collecting system, or fluid filling the collecting system, as in MRI. Here is CT, and here is the ultrasound with the streaky parenchyma. What is this? This is the typical appearance of erythrocoel, bilateral with halos on around. Bilateral erythrocoel is larger on the left. The cobra head sign, or the cobra onion sign, spring onion sign, refers to the dilatation of the distal ureter surrounded with thin lucent line, which is seen in patients with an adult type erythrocoel. The presence of this cobra head appearance is an indicator of uncomplicated erythrocoel who have the simple type of the orthotopic of the intravesical vesicular junction in normal position in the trigone, almost always confined to the adults, bilateral in 30%, but we have the more common the ectopic, which is extravesical. 80% are unilateral and are inserted into the bladder neck or outside the renal bladder, and almost always associated with duplicated collecting system. Thank you.